first area of questioning is that people are dying. So what I'm wanting from each of you, please, is are practical and immediate steps where South Asians can prevent contracting COVID, spreading it and dying from it. And what should we do?
We believe there should be a risk assessment. There should be a risk assessment of all workers that could be exposed to the virus, and to make sure that BAME status is considered a risk factor, just as pregnancy after 28 weeks is a risk factor, just as some other medical conditions are a risk factor. And when you assess that risk in conjunction with other factors, you then can make a decision on how that worker should be deployed, or whether there should be additional protections. And in the NHS, might I add, there is a host of work that you can do other than COVID front-facing work. The NHS has to provide its non-COVID services. We know that there's a big backlog. You can provide remote consultations, and you can do other non-patient-facing work. So I think that needs to be done immediately.
The message has landed with some of us in terms of how serious this is. And then there's a lot of us that haven't. So I'm on a family chat with 30 of my cousins, and when I informed them that the deaths among the main BAME community was highest, it hadn't landed with majority of them, and that's a bunch of young people. So that's a bunch of literate, educated, westernized young people. So if it hasn't landed with them, can you imagine how it's not landed with my mum's generation of people? So I think there's something about faith leaders, community leaders, shops, services that we are accessing, really getting how serious this is, and ensuring that we are protecting each other. And I would say that is the first step that needs to be taken. But how do we mobilize that? I guess that's a conversation that we can have, because if we keep looking to government, who, frankly, if you look at the public messaging, usually white blokes on a podium, talking middle-class language, that have been leading this initiative, great, but that doesn't speak to my mother.
Early on, we realised that something wasn't right, and that BAME doctors, nurses and health workers were dying disproportionately to their white colleagues. And Dr. Nagpal came out with this stunning statistic of 94% of doctors who've died on the NHS frontline being BAME. Dr. Chand, if I can turn to you as the honorary vice president of the British Medical Association, why do you think this is happening?
And I think one thing which has come out very clear, and I call it naked inequalities, which has surfaced with this COVID, we have to really look into it. For God knows for how many years since I've been part of NHS, we know that discrimination and racism exist in NHS. God knows how many inquiries been done, but nothing substantive has been done to structurally look into it, why racism affect that. And I think COVID has brought that on to us, and we look into it, what we do about it.
But people are dying right now, Dr. Nagpal. How do you get the government to listen if these inequalities have been going for years and years and years?
Yeah, so clearly what the government must do is make sure that that all medical directors and all trust hospital and in general practice CCG managers absolutely understand that they need to make sure that all sectors of their workforce are able to speak out without any fear of recrimination. We're also going to be, and I'm going to be writing this week to all doctors to remind them that their safety counts, and if they feel that they're unfairly treated, and secondly, remind them that all deserve a risk assessment. So if you are a 60-year-old Asian doctor who has diabetes and hypertension, that doctor needs to be risk assessed and protected. It's just not right that is not factored in.
The danger is, as we come out of the pandemic, we just simply restore elective and urgent care, and we provide urgent care to our populations. Whereas if we really want to address health inequalities, we've got to work upstream in terms of addressing the social determinants of health and prevention, so that people don't get to the stage where we have high levels of diabetes and obesity, etc. So I think it's not too late to try and protect ourselves from the future.
So that's the preventative messages you want to get across?
Absolutely, and I think it ought to be a driving principle as the health systems come out of the pandemic.
Dr. Nagpal, how concerned are you about the messaging not only now about preventative, what's happening right now, but as we move on, because the lockdown is easing, how concerned are you that the messaging isn't quite right there?
So I am worried because with the easing of the lockdown, we know that the BAME community is overrepresented as key workers. More of them will be using public transport to go into work. More of them will be going back to doing other essential work that as things are opening up. And my biggest worry is that people may be under a false sense of security that all is well. The circulating levels of the virus are still high. So I just want to avoid a second peak, and we need to make sure the messaging about adhering to the same hygiene and infection control measures are just as relevant now as they were at the beginning of the pandemic.
So what does a campaign look like right now then from the NHS? What that's aimed specifically at South Asians, that doesn't cause panic, but is constructive and helps save lives in the immediate future?
From my perspective, I think it's a very straightforward and simple message that in order to protect oneself, measures such as social distancing and maintaining extremely high levels of hygiene are fundamentally important, and we need to make sure that continues for as long as possible.
I think we're missing again elephant in the room, that is lifestyle and diet. I think we got to give this message. This is the right time to tell that particularly Southeast East Asian people's diet is full of starch, full of sugar. We got to really cut down on those, and we got to really make sure that exercise, the sleep, these things are very important. On an optimistic note, I think we should give this message. Whatever dreadful this virus is, still 98% of people get very mild symptoms. It's only 2% of people, and we got to make sure that those 2% people are protected.
And I think, how do you get that message around risk assessment for our community, and how does the NHS promote that, is a message that I would like to put out, if you want a single crystallizing under a single term.
We need to go back to the basics. Engage community health workers. I mean, they can actually, they can do lots of things, because we know that it has worked very well with midwives, for instance. I think many historically. So we need to really, I think there's a cadre of community health workers that could be deployed, and who could actually go and not just educate, but also, trace and track conditions. Like, for instance, as we have talked about multiple morbidity, multi-morbidity is really increasing in the community. It's not just among BAME community, across the board.
We got to address the so-called inequalities. Inequalities is one of the basic fundamental reasons that so many people have died.
We know from disasters around the world that from the spike of any crisis, about 4 to 6 months later, we have a decline in the population's mental health, and about 40% of people's mental health will decline. So if you then overlay that with the health inequalities discussions that we've been having, so if you've got no job, you've got a diagnosis of depression and anxiety, you've got an autoimmune condition, and you've now got the impact of the trauma that we are going through as a nation, and a decline in mental health, that is a catastrophe waiting to happen. So I guess what I'm saying is there's a second pandemic, which is the mental health crisis, that's 6 months from now. And what are we doing to support and prepare our communities around their mental health and well-being?
BAME status is an independent risk factor for serious illness and possibly death from COVID. That it places an obligation on the NHS and all employers to make sure that they risk assess that additional risk and put in place adjustments to protect those workers. And it's not about all BAME workers not being able to work on the front line. That's not what it is about. Assessing those at highest risk, and there are tools out there, and there need to be adjustments. The second is data. At the moment, we don't have enough data. We only are talking, all of this discussion has been about death. In fact, in where I practice, I've seen a lot of serious illness of patients being hospitalized. They do come out of hospital 3 weeks later, but that's been a significant toll on their own families, on their own personal health, etc. And we have no data about hospital admissions around the ethnicity, the type of job and occupational factors that may have caused that illness, whether they had PPE or not, whether they were a bus driver, etc. So I think we need both. We need more data, and we also need protection.
I think we all know that we are the highest death rate in Europe and the second highest in the world. Why we are where we are, I think this needs a definite independent public inquiry. I think that's what perhaps I would ask and beg Health Secretary that let's have, and that inquiry should be held and chaired by somebody from BAME community who knows about BAME community and he knows the health issues.